Hi everybody, I'm Phil Liggett. They call me the voice of cycling, and I was a special guest on episode 85 of the famous Physical Performance Show, which is approaching its 200th edition now in February 2020. I just want to say congratulations to all the guys involved. It's a great listen, and I really enjoyed the small part I played in it. So here's to a very successful and happy new year.
And the winner is...
Failure is not an option.
I've had my ups and my downs.
I think it's an absolutely breakthrough experience.
Welcome to the Physical Performance Show, the show designed to inspire the pursuit of your physical best performance. I'm your host, Brad Beer. Listen in as we delve into how the world's top physical performers achieve their success, as well as the highs, the lows, and the journey of getting there. Let's get ready, set, let's go. Welcome to the Physical Performance Show, brought to you by Physiocram and Pogo Physio. I'm Brad Beer, sports physiotherapist and exercise scientist by trade and training, and founder of Pogo Physio. Each week, we'll aim to bring you the latest and greatest information and inspiration designed to help you perform at your physical best. We do this across a range of different episodes, expert and featured performer episodes, coaches' corners, and the occasional interest edition. And at the top of the show, you heard from featured guest of episode 84, Phil Liggett, the voice of cycling himself. And as Phil noted, we are fast approaching here at the Physical Performance Show our 200th episode. And it really does astound me. I recall thinking 50 was quite a milestone, and here we are, almost at the double century. And it certainly wouldn't be possible without your support. So thank you for tuning in. And this is also an important episode, the final for the 2019 calendar year. And also, we will be announcing the winner of the annual Physical Performance Show feedback survey and the winner of the $50 Amazon gift card. The team behind the scenes are also busily working on putting together two best of episodes for 2019. The first will be the best of the expert edition and coaches corners, and the second will be the best of the featured performer episodes. And they will follow today's episode. But before the 2019 year closed, I felt it pertinent to share a recent conversation I had with UK-based physical therapist Ben Cormack on all things pain. That's right, P-A-I-N, pain. Now, physical pain is something that we all have to deal with between the cradle and the grave. As athletes, people out there pushing their own physical limits, we deal with pain regularly. And today, Ben Cormack will share with you why it is that what we feel with regards to pain doesn't necessarily determine the state of our bodies or how we should necessarily act. Ben shares some really wise insights as a physical therapist around how we need to perceive pain, the misconceptions that exist when we are in pain, and how the medical system can best assist people in pain and help get them back to their physical best. By way of bio, Ben Cormack owns and runs Cor-Kinetic. Ben's a musculoskeletal therapist with a clinical background in sports therapy, rehabilitation, pain science, and exercise stretching back 15 years. Ben specialises in movement and exercise-based approach with a strong education component and patient-centered focus. Ben is a highly popular international presenter who has delivered conference presentations and courses all over the world. Just recently, Ben has also teamed up with former expert edition guest of the Physical Performance Show, Adam Meakins, and together they are launching a project named the Better Clinician Project, aimed at helping equip clinicians worldwide get better results for their patients or clients. So get ready with a pen and paper. If you think you have a good handle on pain, then this conversation may have you reevaluating. Here is my conversation with Ben Cormack, UK-based physical therapist, on all things navigating pain. Ben Cormack, Cor-Kinetic, physiotherapist, It is an absolute pleasure to welcome you to the Physical Performance Show. We have been trying to line this up for some time.
Thanks for having me. I really appreciate being able to come on here and have a chat.
You know, the theme of this show is helping the listener to perform, to pursue their own physical best performance. And, you know, one of the things that I've admired about your contribution online in the digital world of health professionals and performance, if you like, is your skills around articulating things about all things pain and the interpretation of pain and what it does and doesn't mean to the individual out there trying to be active. So let's focus the conversation around that. And before we jump in on the content, can you paint a little bit of a picture on how you found your way into this world of physical therapy and a little bit about what a week in your world looks like?
Yeah, absolutely. So originally I studied what's called in the UK sports therapy, which was many, many years ago, back in the late 90s, just kind of inching my way into the world. I've gone on and done an MSK. I have a personal trainer qualification. I've worked a lot in professional sport, both kind of in the trenches and also also later on in my career going back and working in more of an educational capacity with lots of premiership clubs and, you know, lots of rugby clubs and these kind of things. And I think many, many years ago, the way that brought me into it all was that my sport is boxing. So I actually went boxing this morning before I've done this, just to get my bit of fitness in. And I was kind of a little bit lost about what to do when I was about 17 or 18. And my friend said to me, well, why don't you go and study something that takes you in that kind of path? And so I kind of fell into it from a sports perspective. You know, most of my training, etc., is around sports. As I said, I studied sports therapy. But since then, I kind of think that having flirted with the world of professional sport and things like that, my interest is really in things like pain and working with people with long-term pain. And so what would happen now? What would my week look like? Well, it depends on the week. I do lots of travelling and teaching with Cor-Kinetic. You know, that involves taking me, whether that's, you know, internationally or within the UK. I still see patients maybe 4 to 5 hours a week. Tomorrow night I'm giving an evening lecture in London. And then just generally keeping up to date with lots of the research and the data. And, you know, you do that so well, Ben, the up-to-dateness, and you do not seem to sit still for long. You mentioned some international travel there with your teaching, your coursework. Most recently, where have you been? You've been, I think you've been island hopping to some degree, haven't you? Well, I just got back from Chicago. I was out with Entropy with Sarah and Sandy for a little bit out in Chicago. In the last few months, I've been to Morocco, I've been to Holland, I've been to Belgium, I've been to Spain a couple of times, I've been to Italy. So I probably maybe hit about 20 countries a year is about my average for teaching. Yeah, wow, what a passport. Ben, let's talk about this concept of pain. You recently put up a fantastic post on Instagram around the differences between pain, this thing called nociception, and damage. But to the everyday individual, active person out there, you know, what is pain and how do we interpret it? That's probably the biggest question anyone's ever asked me. There's been guys searching for the answers for this for the last 50 years. So I'm going to flirt with the question. I don't know if I'm going to hit it out of the park, to be honest with you. I think that the real big message, and I think that's what I was trying to get across with that post, is that often we kind of mistake what we feel for the state of our body. And I think that has a really, really profound effect on people's behaviour. So what I mean by that is that, you know, a lot of people stop moving, for example, because they feel pain, and they directly relate pain to the idea that we have damage to our bodies. More pain equals more damage, so therefore we should desist from doing things. We should stop moving because we're going to cause ourselves more damage. We're going to make the problems worse. Now, one of the key messages, I think, from the world of pain science, whatever that might be, is that, you know, what we experience, what we feel, does not directly relate to the state of our bodies. And some of the wonderful research we have coming out now within tendons, within lower backs, etc., is kind of really starting to prove to us that just because something hurts more doesn't mean that we are going to have a worse outcome or we are going to have more damage. And I think that is a really, really key message around pain. I don't know if I can define pain per se, because pain is one of these uniquely subjective experiences. So your pain and my pain are probably two very different things. But I think there is a key message that what we feel in terms of the intensity of pain doesn't reflect the state of my body and shouldn't define the behaviours that I take. And I think that's probably the key message that I could give around pain. I've probably moved a little bit away from defining it as an overall thing. I think it's become much more subjective to me as a thing. But I do think that people need to appreciate that what we feel does not reflect the state of our bodies. And that's a really, really important message.
Ben, just to clarify, so the listener out there that has a running-related injury, say a bone stress injury to the shin or the tibia, are there caveats to that where the pain does reflect damage, obviously?
I think there are less and less caveats because there's work by, one of your Australian counterparts, people like Jack Hickey, that's starting to show that even acute muscle injuries, actually there is a certain amount of pain that seems to be okay to experience. But I understand completely your point. There are some times where there are going to be injuries, medial tibial stress syndrome, bone stress fractures that do probably reflect an element of that pain that we experience can be reflective of our bodies. But I would say actually the instances of those are much less than we previously thought.
Yeah, and I mean, from my 15 years in the profession as a physiotherapist would second that, Ben. I remember the first prac we did in physiotherapy school, Ben, was everyone putting their legs in ice baths and leaving them in there as long as you could. So obviously there was a variable degree of exposure, and then rating that feeling of discomfort or pain, if you like, on a scale of 0 to 10. And, you had someone with their legs in there for, 10 minutes, someone with their legs in there for 10 seconds, and, the scores. And it was just a really fun experiment, if you like, to see 30 people with different scores, different interpretations. And I remember just thinking, okay, wow, what are we embarking on here?
Yeah, what have I let myself in for? It's the electrician's also.
And then, it really feeds into one of your recent posts, which I thought was brilliant. It said, what we are often taught that dealing with people in pain is like a well-ordered orchestra. Just follow the notes or the algorithm. In reality, it's a lot more like jazz, a whole bunch of craziness and improvisation.
Yeah, I think that, we talk about clinical experience not always being a marker of a good outcome. But I think there is a really valuable part of clinical experience that allows us to have seen a lot of craziness, a lot of madness, a lot of variability that helps us organise and work with our patients or the people we work with. And I think that the more time that we spend working with people, the more we realise it doesn't all go to plan and it doesn't all fit into these neat little boxes. And experience, I think, helps us navigate some of that within the clinic and realise a lot of what we really do as therapists and working with people is very much trial and error. We have an idea about what the data says, what the evidence says. We have experience of working with people, working with patients. And somewhere along the line, we have to organise that into a workflow where we're interpreting what people tell us, where we're trying to navigate that with interventions. And, you just have to get used to playing a lot of different notes on a lot of different scales rather than expecting it to fall neatly into those boxes.
And sometimes there's harmony and sometimes there's absolute disharmony.
Oh, without a shadow of a doubt. And sometimes, again, that's a skill, isn't it? It's navigating the disharmony. It's realising when you need to take a back seat, when you need to take a front seat, when you need to put certain things first. And again, I don't think that is really reflected in an algorithm. It's not reflected in a flowchart.
Yeah, absolutely. Ben, one of the insights I observed you share recently, which really made me smile because I sort of had this epiphany myself many years ago, or several years ago, I should say, is that people don't walk to the injured listener out there carrying an injury of some kind, they don't walk through the doors of a health professional because they are in pain. They walk through the doors of the health professional to seek help because they're experiencing an inability to do something that they love or that's meaningful to them. It's the frustrations of not being able to participate. It's the fears around what that pain means, and the anxieties around what it's triggering. So can you please speak to that around, I feel many people aren't even aware on their own reflection that they're not coming to get pain relief. They're actually coming for a deeper reason. And sometimes I observe the lights go on right there in front of me when you help people join the dots as to why they've actually come. So in your experience, Ben, can you speak to that concept?
Yeah, I think there's a whole bunch of reasons why people come to see us. And you kind of named the majority of them there. I think probably the biggest one is actually worry. I think most people want to know, what is this problem? Is it going to be a bigger problem? Is it going to be the problem that my Uncle Bob had for 25 years that stopped him from doing this? And I think that people work vicariously around the experiences around them, don't they? And I think this is why chronic back pain is such a big problem. I think that they suggest that 40% of all chronic pain is back related. And what that means is that chronic pain is really a bigger problem than just you. It's what you see in the media. It's what you see in articles. It's what you read in the paper. And I think a lot of people want to know, what is this problem? Is it the big problem that everyone else has got? Is it going to affect my work? Is it going to go on for months? Is it going to get better? What can we do to help it? So I think that really that's part of the kind of the clinical skill, isn't it? It's finding out to some degree what people believe and what pain means to them. Does it mean that they're going to be disabled? Does it mean they can't play with their kids? Does it mean they can't go to work? And I think we need to then get into finding out what it stops them from doing. No one ever just came into me and said, I've got pain. They'll say, I've got pain or it hurts or I go for a run and it hurts 2 miles into my running. And instantly that kind of tells me that really what you've really come to see me about is that you can't run. And running is really valuable to you because it's your stress relief. It's that sign that you're a good functional human being and you want to get back to running. And it's not really the pain, because what would be a great way to get rid of pain for someone who runs? Don't run. Yeah. Right? You've got pain when you run. I can take that away in an instant. Don't run, right? But the running is meaningful. The running is part of the identity. The running is what I do to keep me fit and healthy and means that I'm a functional person. So that's really what someone's telling us, aren't they? That they value this activity and they can't do it. So to tell someone not to do it would solve the problem, but it wouldn't solve the real problem.
And it seems to be the easy advice is, well, don't do it. But obviously it's not the targeted, targeted treatment, if you like, that the individual's seeking. And would you therefore infer that a good process really begins with the end in mind, i.e. what you just described, the individual wants to run. So how many times a week, what sort of quantity, whatever the output or the physical activity is, let's start there and let's reverse engineer where you are to get to that point. Yeah,
and I think one of the things that I think is important that we have to realise is that when you have a runner, it becomes quite apparent what the goal should be. When it really becomes tricky and difficult to reverse engineer is when you're dealing with someone who's had long-term chronic pain, for example, or persistent pain, and maybe what we don't see is a definitive goal anymore. One of the big things that we see from the literature around persistent pain is that people's lives shrink. Their understanding of what they want to get to do and who they are and what they function, it all kind of becomes myopic around this concept of pain. And I think that's the real challenge. When you work in sport, it's often quite clear what some of the goals are. Sometimes when you work more with a persistent pain population, the real challenge is bringing out some of those meaningful activities and being able to get that kind of goal that's meaningful to people. I think that's the real challenge often.
Yeah, no, it's that's well said. Ben, you used the phrase there, persistent pain. I observe some often labelling of people's presentations by themselves or perhaps other health professionals or well-meaning friends or family that they have developed chronic pain because they've had it for some time. So can you speak to this concept of descriptors or labelling around this persistent state, or chronic as it seems to now be a bit out of vogue? So, but to the listener there who may have had a condition for some time, experiencing symptoms, can you speak to this concept?
Well, if you think about chronic really is a measure of time. So acute pain would be kind of, however, 1 to 2 weeks, and then subacute, and then chronic, which suddenly magically happens at like 12 weeks, of course, although it doesn't. But it is just a descriptor of time. Unfortunately, I think the word chronic is misinterpreted. People often think, I've got it forever. It's worse. There's acute pain and there's chronic pain. Chronic pain is worse than acute pain. It is no measure of the intensity of pain. It's a measure of the duration of time. And I think that there's two factors here. One is I think that chronic is misunderstood. So I think there is a case for changing the word chronic to long-term or persistent, right? But the other point is there are people out there and people who are told regularly that they have chronic pain, and this is the label that they understand and they're working with. So for me, when someone comes to me and says, I've got chronic pain, my first question would always be, what does that mean to you? What does that, what any pathology, any label, the first thing that I want to know from a person is, what do they understand about it? Because partly some of the problems arise around labels and around diagnoses is that people misunderstand what they mean. So they can appear to, it's like scans. You get a scan and it says modic change and this and what the hell do some of those terms mean? I don't even know, and I'm a health professional. So human beings like to fill in the blanks, don't they? I think naturally human beings, we go to a very pessimistic state. It's probably a biological thing for survival, right? But at the same point, I think we need to help people understand what things really mean. And we need to work with the labels that they have, but I don't think sometimes we always need to perpetuate the labels if they are not helpful. I don't think chronic pain is a helpful label because it's got a high risk of misinterpretation. But I also appreciate, and this again is the nuance, that there are many people out there with that label, and what we need to do is find out more about how they perceive that concept and how we can provide some better information for them to kind of work with.
So it's all about reducing that risk of misinterpretation and really de-threatening the experience.
Yeah, I think this is one of the big things is that so much, I think human beings are, we like to make our own rules and decisions and understanding of things. Even if we think wrong things, it takes a lot for something to change our opinion, even in the face of lots of different information. We like to trust what we believe, which is cool. But at the same point, I think sometimes that can create problems within itself, and that we always need as health professionals to give the best, honest, realistic information that we can. I think that's one of our key roles, is to always be able to give accurate information to people that's realistic and allows for an open discussion around that information.
You teach on the dimensions of pain being sensation, emotional, behavioural. Yeah. Can you speak to those dimensions?
Well, I think it's important that we understand that there are some different areas here. So there's what I feel. Traditionally, within the clinic, we kind of, ask people how much does it hurt? Where does it hurt? What does it feel like? And I think these are the sensory dimensions of pain. And I think they're important. And we use those diagnostically generally, don't we? That's kind of what we're trying to gather that information for, to make, does it feel like lancing or burning? Is it in a similar location? Does the intensity go up and down? How much does it hurt, etc.? But then I also think there are other dimensions. I think there's the affective or the emotional dimension. And I would describe that as not how it feels, but how it makes us feel. And I think this is one of the biggest problems within pain, especially more persistent pain, is that we don't take enough notice of how it makes people feel, how it demotivates them, how it makes them anxious, how it makes them down and depressed, and this then directly affects things like motivation, which affects behaviour. So we have how it feels, we have how it makes us feel, and then I think it changes how we behave and how we act. And I actually think the last two are more problematic than the first. when pain goes beyond just how it feels into affecting us, who we are as people, our role within society, our sense of self-worth, our sense of meaning. If you go back to people like Viktor Frankl and that man's search for meaning, when man doesn't have meaning, that becomes a big problem. So, if I don't have a role within society because I don't feel that I can function because of this pain, that's when it becomes a real problem. So I think the real problems are when we move beyond how it feels into how it makes us feel and how it makes us behave.
And practically, how can we gauge those two other dimensions? I think any health professionals probably well trained in gauging the sensory component, except for that word lancinating, or that phrase lancinating pain. What does that mean? I've never been struck with by a lancet. I don't know anyone that ever has. But
I got chased once. Yeah.
Leaving that one aside, but how do we best gauge these dimensions of emotion and behaviour?
Yeah, I think what we're trying to do, and I think this is really what the biopsychosocial model is really about. And what I want to point out when I'm talking about this stuff is I don't always know if we have to treat these things. I think that's really important that we point out sometimes it's not always about treatment. But I would like to gauge very much, who I'm working with, what's their level of motivation, how do they feel about engaging in life? Are they down? Are they depressed? Are they, scared of moving? Are they fearful? Because these things will directly relate how your treatment is. If we want people to get out there and to move, and we want to get them back to work, and we want to get them back functioning, these are the things that are probably going to limit that, not just how this pain feels. So for me, I'm just trying to get a sense of, who is this person? What is their level of motivation? And I think there's a couple of ways that we can do that. So firstly, we can go down the road of looking at things like questionnaires. You can measure lots of different dimensions. And the argument would be, I can measure self-efficacy. I can measure pain self-efficacy. I can measure fear avoidance. I could measure passive coping. All of these different dimensions via things like questionnaires, right? But then I think there's much more of a humanistic thing, that there is something that we can't always put our finger on, a special source. And that's kind of just understanding being with people. And maybe that's an experience thing as well, is that you gauge, is this person in front of me, are they upbeat? Are they talking about things in positive ways? Are they very negative? Do they have lots of barriers? So we can gauge it in a more quantitative way. And sometimes I don't know if these quantitative things actually measure what they think they measure. But then I also think there's just a sense of trying to work with a person in front of you. And maybe that's a skill that cannot always be taught. Maybe that's a little bit of a reading people skill. But certainly we need to ask people more about things in their world and things in their life, not just about how that pain feels.
I recall my wife, who is trained as a medical doctor here in Australia, coming home and from an education event saying, we just learnt to ask a really important question in history. And I said, what is that? And she said, Christina, my wife, how does that make you feel? And I was like, wow, that's a powerful question. And I remember incorporating that some time ago. And I often say that tears in a consulting room are good. If there's tears, not that you want everyone to be in tears, but when people feel comfortable enough to show that emotion, I feel that I'm actually at that point connected with the person that I'm there to try and guide towards. And often I find it's that question, how is this making you feel? Then I zip my lips and just give it time. And you often see the lip quiver, the eyes start to water. And all the talk about the pain description, 0 to 10, or where it is, or whatever the descriptors may be, sort of melts away at that moment.
Yeah, I think you've hit the nail on the head. I think it's just showing that you are another human being who cares about another human being. And, and I think that is probably a really, really powerful, I don't know if it's a therapeutic effect. It's part of the therapeutic process, that actually someone is listening to me, they actually care. And that I think that goes a long way. And really that comes back to doctoring, doesn't it? And I think that doctoring is much further ahead than more physical therapy things like we do, simply because there's not anything that they can do. They can't roll you over and do a minute. But it's true. They have to work with subjective presentations. Most diagnosis in the world of medical is done purely subjectively. There is no physical examination. We have lots of physical things that we can do, and I think sometimes that stopped us from expanding into this world of understanding people better and their behaviours and some of the other things going on. And I think that where we've really made a mistake within medicine is we've really dehumanised it. We haven't got family doctors. We haven't got people that know us, that know about our situation. We've got 10 minutes with someone we've never met, and they're trying to do a kind of biomedical diagnosis on us. And sometimes the best thing that we can do is validate, listen, understand and care, and I think that goes a long way.
Yeah, wow. Putting the human back in healthcare. Ben, you mentioned two words or two phrases there that to the listener may be unfamiliar. The term biomedical, and then prior to that, you mentioned this term biopsychosocial. In the simplest terms, can you wrap some context around those two weird and wonderful words?
Yeah, I think that the best, and this is work by a guy called George Engel many, many years ago, and, he built on work from other people as well. I think it's understanding that the biomedical is simply about finding a diagnosis, fixing the problem. Whether that's something medical, whether it's something physical, and we are not concerned. It's about, what can we empirically measure here right now and what can we fix? And that would be through drug therapy, that would be through operations, that would be through fixing the pathology. And there's been work by other people like Leventhal who've kind of separated this into the disease and the illness. We have the disease, the pathology, the problem. But then around that, we also have this whole other world of the way that it affects the person. So if we think we have these biological, and, I'm going from biomedical to biological. If we think about the biological, we could say, everything is biological. Everything we do is underpinned by biology. Most pathologies would be some kind of biological problem. You mentioned medial tibial stress syndrome or what we might term shin splints or stress fracture, right? So that's the pathology. Biomedical would say, put you in a cast, send you off, that's fine. Biopsychosocial understands that I can't run now, that affects how I feel. That might be my stress relief. I might have fears that I'm never going to get back to running. That might affect my motivation. It might be that my whole social life is driven around going to the running club and being with my running buddies. And what we have is this embeddedness of us within the world, and understanding that injury is not just the injury. It's how it affects my belief structures, how it affects my social life, how it affects my ability to deal with stress, how it affects my family, how it affects my work. And so it's not just the pathology that needs to be fixed. It has this huge impact into all these different areas of my life that affect my recovery, that affect maybe how I get back to doing these things. So it's seeing the problem as more than just this myopic diving into the problem from a molecular level, but it's expanding out and saying, this is a person with a problem embedded in the world, and we also have to deal with that as well, not just this pathological biomedical scenario.
The macro versus the micro, in many ways, and it's so interesting. I probably feel like the work, which is just the guide of the rehabilitation process that we may do, is most appreciated when that latter approach is really evident and they feel connected, they feel understood, they feel validated, they feel hopeful, they feel reassured. In many ways, I feel we could do nothing physically in terms of touching someone, assessing someone, just listen, reassure, those things, and people would walk out feeling relief. It's fascinating.
Yeah, well, I think that's really what a lot of people come for. Let's take acute lower back pain. Mm-hmm. We are not very good at treating acute lower back pain. No one is, right? So, it has a natural history. 88% of people seem to recover within about 6 weeks, right? So that might be down from an average of around 5 on a VAS down to maybe 1.5 on a VAS. So what am I actually doing for a person within that time? Most of what I'm doing is saying, you know what, this is painful, but I'm going to do some things that, look at whether it's more than painful. So I want to know, how's your bladder and bowel function? I want to know, have you got anything sinister that might be going on, like weight loss or, or what's your previous history of cancer, etc. Are there anything specific? Is it radicular? Could there be a radiculopathy? Something that might be affecting nerve function? Is there some kind of, something going on? And once we've ruled all that out, which we know only makes up a really tiny proportion of back pain, what I really want to do with someone is say, you know what, the best way to get over this is actually get back to doing life. So it might hurt. Some things might be out of bounds because they're a little bit more uncomfortable than you're happy with. They're beyond what you feel is tolerable. So we're gonna put those to one side. But the majority of dealing with back pain is not actually reducing pain. It's learning to live with back pain better until it takes this natural history. So for me, mostly what I'm trying to do is give people more information about back pain, accurate, honest information. I'm trying to give them reassurance through, doing my job in terms of physical exam, looking out for things that might be really, really serious. And then I'm trying to give them a plan of action that enables them to navigate their problem while it happens, while it's there. So none of that would maybe be determined as traditional treatment, in terms of I'm not really rubbing things, I'm not poking things, I'm not popping things, but I'm giving good information, I'm giving reassurance, and I'm giving a plan of action that allows people to navigate their everyday life with the minimum of problems from this painful issue.
And Ben, if people are engaging, they've got a concern, an injury, if you like, and they're going to seek help from a health practitioner, and they don't feel like the questions or the insights we've just shared are being asked, what advice might you give to that individual who feels like they're very much being treated as their condition and the whole, I've heard you talk, reference that, the donut and the whole type approach, the whole individual's being neglected? One
of the issues I think we have, Brad, is that people don't always know what healthcare should be. Healthcare has done a wonderful job of creating a scenario where it manifests it as itself. So people have expectations from healthcare that are created by healthcare. If you can get a drug or a manipulation that magically takes care of your pain, if you've been sold that story, why would you not go for that? Why would you not expect that? But essentially, I think that, if you are going to seek help, if someone's magically just offering to take whatever issue you have away, that would not be in line with our best medical data. And I think we need to be realistic, and I think that people need to, maybe our ideas of what healthcare is need to change on a much more global level. But certainly I think if people feel like they are being treated as their condition, then they probably need to seek out someone who actually, is going to treat them as a person, their goals, their beliefs, their concerns. One of my chief questions is always to say to people, what's your biggest concern? What is the biggest thing that's affecting you right now? What do you really want to ask me? Because I want to know, how can I reassure someone? How can I give targeted information if I don't know what that person's thinking? So my first question is always, what do you really want to know? What concerns you the most? How can I help you understand this better? Yeah,
so giving people reassurance around that concern. That's a great question, Ben. What's your biggest concern?
Otherwise, you could give people a lot of information that never addresses the concern.
Yeah, and that individual won't leave a healthcare interaction feeling like they probably got what they wanted. They'll go elsewhere, or they'll keep going until they get it.
Yes, absolutely. Therapy shopping. Yes, absolutely.
Which is, just wasted resources all round, let alone the impact on the individual.
Totally. I couldn't agree more.
You're listening to Ben Cormack of Cor-Kinetic, sharing around all things navigating pain for the active individual. Support for today's show comes from PhysioCrem. PhysioCrem is a topical massage cream containing natural plant-based ingredients, ideal for the temporary relief of muscular aches and pains. If you're conscious of what you put on your body, you'll be happy to know that PhysioCrem does not contain parabens or hydroxybenzoates, and its non-greasy formula doesn't leave any sticky residue behind. PhysioCrem can be found Australia-wide at your local Coles, chemist or health store, as well as via their online shop. PhysioCrem have generously offered listeners of the show a 20% discount for all products found online simply by using the coupon code POGO, capital POGO, POGO, when you shop at physiocrem.com.au. That's FISIOCREM.com.au. Hurting sucks, and PhysioCrem have got your back. Support for today's show also comes from Pogo Physio. We exist to help you get back to your physical best following injury. We want everyone who walks through the doors of Pogo Physio to complete their rehabilitation, get back to their physical best, and in doing so, cross the physio finish line. To find out more about Pogo Physio's award-winning services, including our 1-hour initial appointment or our popular online telehealth consulting services, jump over to pogophysio.com.au.
Hi there, Ben Cormack here, owner, founder, Cor-Kinetic, musculoskeletal therapist, and you are listening to the Physical Performance Show.
Ben, you are a huge advocate and highly skilled in the world of exercise as an intervention. So, can we go there now? How is exercise, for the person in pain, as we said, it's a highly subjective experience, but this concept of throwing exercise at someone in pain, if you think about it just practically, is quite amusing. So can we start to lay it down, break into this, how this can be useful as an intervention?
Yeah, I think when we look at the evidence and the data, we do see that moving the body does seem to be the best of what we have to help people. For some reason, it does seem to show the best kind of effects, certainly for my speciality area, which would be back pain. All right. One of the things we have to also realise is the effects are very variable. So we can't guarantee exactly what that. Some people, exercise is the best thing since sliced bread. It's I'm the second coming of Christ. For some other folk, it has very, very minimal effects. And I think we need to be aware of that and we need to be comfortable of that. Do you know what, really? If someone was to say, why do I get people moving? And I don't know if I am totally about exercise, but I'm very much about moving. All right? I think that's the key factor. For me, moving is a really, really good way to show people they are functional. They are able to navigate this world and they are not disabled. They are not useless as human beings. They are capable. If you look at patient goal setting, and I think I think she's an Australian, actually, a woman called Tanya Gardner, who I've got a little bit of a research crush on. I love her work. And she looked at goal setting. And, what we measure as therapists, so we measure strength and we measure range and we measure all these other arbitrary things. And none of those things align with what people really want. But what people really want, about 50% of that, which is a huge majority of all the different things, is physical. So physical activity relates to the vast majority of people's goals. And I think that my aim is never to get someone exercising. I don't care if you exercise or not. That's your deal. If you exercise, that's great. But I at least want you to feel like you can. I want you to feel like you can move. I want you to feel like you are capable and you are functional. And exercise is a really good way of getting people who don't move a lot to move more. And it's not the only way, but exercise is something that's constructed. Exercise is something that's, it's a construct that people understand. All right. And because of that, we can put it into a neat little package in a neat little place like a gym or going for a walk or whatever. And people understand it as a construct. And I think that's really, really important for us to work with. I think exercise is a great way to get people moving. I don't think you have to exercise, but I do think there is an aspect of physical activity is important to human beings, and maybe even more important than that, it's the belief that I am capable of being physically active that's the most important.
Yeah, that's a powerful delineation, Ben. It's about moving, not so much about exercise per se, but the underlying driver there is, as you say, to show people that they are capable, that they're not immobile or unable to pursue the things that are meaningful to them.
You are strong and you can do it.
So, Ben, practically for the individual with, say, lower back pain, how would you, for example, use that you just shared to put that into practice with someone that's sitting there before you with a sore back? They're afraid to put their shoes on to bend forwards. How would you approach that?
Yeah, so I think we need to delineate a kind of a more general not moving versus a specific not moving, right? So maybe what you're more discussing there would be someone who is fearful of doing an activity, or a specific activity is quite painful. I would delineate that from a more general activity using your body sense. But let's use your example. That's maybe where we would be thinking of something that's more around specific exposure and actually getting people to do something, which again is driven by belief. It is getting people to actually start to engage with something specific. So if I delineate that from general to specific, it might be that if someone's standing before me, I would like to know why they don't want to do it. So is it just because it's painful? How much pain is there? So it might be that it's 10 out of 10 pain, and, that might be something that we want to avoid for a little bit, because it's really a lot. It's more than they can tolerate, and they're avoiding it for a very good reason. Whereas it might also be that, well, it's not so much that it hurts. It's more that I think it's going to hurt, or, I think it hurts. It doesn't hurt that much, but what if I do it and it hurts more? So again, what are we getting into? We're getting into what's the underlying driver here. I hate that word driver, by the way. That makes everything sound linear when it's really not linear. Like the word pain driver, which is complete bullshit to me. But it's this understanding of what really is causing this person to avoid doing this activity. So that's really what I want to get to the heart of. Why are you avoiding it? And what do you think is going to happen? And then I would go more into kind of a behavioural experiment in that kind of sense, Whereas you might get the opposite end of that, whereby someone is just not very active as a person every day, which we might approach from thinking about how do we make this person more active? How do we make them value activity? Even if they have got pain, even if the activity doesn't affect their pain, does it affect them as a person and their belief in their functionality? So, again, separating the idea of function and pain, and separating the idea of a more specific approach and a more general approach.
So differentiating function, pain, a general approach, specific approach, understanding, some of the beliefs around, their interpretation of what they're experiencing. And I guess it's diving deeper and not just assuming.
How much, assumption is it hurts when we bend, don't bend. That's the same as the running example, isn't it? Who would ever say to a runner, don't run? But how many times do people get told when their back hurts when they bend, don't bend? And we forget that. There's the same impact, isn't there? It's the same. We're not consistent with that advice. It's like osteoporosis. What's the number one treatment for osteoporosis? Loading. But if you have a back that's not healthy and it looks terrible on a scan, don't load it. Do you see what I mean? So degeneration in one sense, of bone degeneration in one sense is the treatment is loaded. As soon as it becomes to the back, it's like avoid it. So we have a lot of inconsistencies in our messages. We don't tell people not to run. We don't tell people not to load if they have osteoporosis. But as soon as it gets to the back, we change our opinions and our tunes. And again, that shows it's more about an overall message, a societal message around the back, than it is maybe about the science that we have.
So if you could take out a billboard, Ben, on every continent that you set foot on, the 20 odd in every 52-week cycle, and you can only have one message on that billboard, what would it be?
So we could say, it's important that we respect pain, but we don't fear it.
Respect pain, but don't fear it.
Yeah, the idea that pain is normal, the idea that pain affects us, the idea that, we can have some pain and it will still be okay. That we can have painful exercise for a tendon. We can have painful exercise for backs. We can have painful exercise for acute hamstring strains. That pain does not cause more problems. It's just something that we have to deal with, So I think that we have to, like inflammation is a great example. Like we think inflammation is a bad thing. So inflammation can make things hurt. It makes nociceptors more sensitized. But it might not be that that's around protection. It might just be that's a side effect of inflammation. We don't know. So the overall message that we have that pain is bad within itself. We don't know exactly always why we have pain. Could it be protective in certain circumstances? Yes. But, it's a bit of a paradoxical system because the less you listen to your pain, often the better you do in rehab, right? So is it really a protective system? I don't really know. That would be paradoxical to me. But I think if we can give people the message that, pain is not the enemy that we think it is, I think we would do much better as human beings in terms of dealing with pain. And I actually think that people have been let down by healthcare because healthcare has perpetuated this message.
You're going to take out the billboard, Ben, respect pain, don't fear it. I'm going to follow up with a billboard that I'll put up, which is a quote of Ben Cormack saying, pain is not the enemy that we think it is. And maybe that would start to help people's interpretation. One thing, Ben, I've been really struck by in more recent years in my full-time practitioner clinical practice is just the sheer remarkable ability of the body to mostly get it right, given, some information, in many cases a few guiding principles and time, that, so many things do come good. I spoke recently to a 59-year-old marathoner from Ireland who set the world 59-year-old marathon record. He ran a 2:27 after a few years of, being lost in the wilderness with, extreme drinking, alcoholism. And his son, who obviously has some of these genes, had 3 or 4 years of running in his legs, ran a 2:31 in the same marathon. His father, they set the Guinness World Record. But he'd been partying, hitting the booze, etc., for decades in advance of that, and it really made me think: wow, the body can just get so much right. So, can you add your sort of views and thoughts on the resilience of the human body? I'm amazed that we don't experience more pain, considering the complexity of our structures.
Yeah, look, I think that the problem with resilience is that, as you pointed to there, that kind of genetic aspect. If you go way back and look at some of the work by people like Clifford Wolfe, he did a paper called Trait or State, talking about kind of some of the pain around osteoarthritis. So I think some people are naturally very robust and resilient, and that robust would be a physical construct, resilience would be more of a psychological construct. And I think that the problem, there are some people that we never see because of how robust and resilient they are. Some people never experience very much pain. Some people experience lots of pain, but they're very psychologically resilient to it. And so there are, that would be people that we might describe as copers. They're able to cope with these scenarios. And then there's a whole group of other people that may be, how much does healthcare affect resilience? How much is healthcare an actual risk factor sometimes for destroying people's natural ability to cope? And I think that is that to do with money? Is it to do with, how healthcare has positioned itself? But certainly I think we need to create a positive environment for people to do those things that you described, to naturally flourish. And there's actually a term called salutogenesis, a guy called Anton Antonovsky. And I think that kind of deals with that, is that he would be describing more positive things that we can encourage, healthy behaviours, optimism, rather than a lot of these kind of negative things that we can focus on. So from a healthcare perspective, we should always be trying to create the best environment for that person to be able to achieve what they need to achieve. And whether that's pointing out resources available to them, whether that's helping them navigate certain things that they're having issues with, I don't know. But I think we have this healer complex where we're trying to fix things. And actually, we should be more like gardeners, We're trying to help that seed sprout and grow and point out the best available ways to do that. And I think that, it's a much more ecological approach, potentially, or a salutogenic approach. Resilience is a really quite a complex construct between things like vulnerability and resilience and how that shifts, maybe even on a daily, hourly basis with some people. But I think how can we as healthcare professionals see, our patients as very strong things that sometimes need a bit of watering, or they need a bit of sunlight, or they need something that's going to bring out the best in them, rather than us swinging in and trying to fix these, imaginary problems that we've created sometimes.
And do you feel like it's a real mindset of the practitioner, being comfortable with, ego is part of everyone's, I guess, makeup, but I've found as I've gone on in a career, I feel less certain about things, and really I do feel like all I'm good for is to guide people rather than when I first started I was bullish around, hey, I can fix you. Is it a maturity thing? Is it a mindset thing? What would you say?
So I think it's a bit of both. I have a slide that I use for teaching, and it's called Be the Coach, Not the Star Player. So it's switching to being a coaching mentality away from being that healer, that guru, that magician, into saying things are very grey, I haven't got a lot of clarity, we don't know how things are going to turn out. So is that a mindset thing? Yes. Is it an experience thing? Yes. Because I think that sometimes as we grow as practitioners, our mindsets change and our experience can shape that. So I think it's a kind of a nature-nurture question. That kind of, how does it form? But then again, there are also people that never make those shifts and continue to have that long-term healer concept. Maybe for some of us, it's a trainable, modifiable thing. And for other people, they are not watered by their profession, or they are not watered by people around them to help them sprout new ideas and concepts that might change them from one rationale over to another rationale.
You're listening to UK-based physical therapist Ben Cormack on this, an expert edition on all things navigating pain. If you missed last week's episode, it was a featured performer episode featuring the current World and Super League Triathlon Series champion, dual French Olympian Vincent Lewis. And Vincent really opened up on his career highs, lows, and learnings. It's been remarkably well received, coming from an athlete at the top of his game leading into the 2020 calendar year and 2020 Tokyo Olympic Games. And here's a little snippet of what you may have missed.
The toughest, I would say, Alistair Brownie. Yeah, this guy is a real badass. He doesn't want to lose. He's just going for gold. It's so funny racing him because he's like a mad dog when racing. And as soon as the finish line is crossed, he's just like the nicest guy you can see. And I remember we crossed the line and he beat me because he won and I finished third, I think. And we just look at each other and start laughing, like saying, wow, that was a good race.
To tune into the full episode featuring Vincent Lewis, jump over to wherever it is that you listen to your podcast from, iTunes, Spotify, SoundCloud, or wherever, and enjoy the full episode. Whilst there, feel free to peruse the archives dating right back to episode 1, featuring Surf Lifesaving Ironman champion Ali Day. For now, let's jump back with this week's featured guest on an expert edition, Ben Cormack, on all things navigating pain for the individual. Ben, you prior mentioned scans or imaging.
Yeah.
To the listener of the show who maybe has collected a bag full of scans or images over time, or has just been sent for some imaging and has read their report and is experiencing concern, perhaps panic even, around the words, as you say, they can be weird and wonderful. What would you say to the individual who is looking at their report and fearing the worst?
Yeah, so I want to point out, firstly, I'm no expert in this area, so I don't read MRI reports as a professional. You know, in the UK, you have to go off and have further training for that, and that's not something that I've gone down the road of. But I've seen many scans, and I've sat with many people with their scans. And I think the first thing that people need to understand about images is that's all they are. They are images of their body. So scans don't show us pain. They don't actually highlight where it hurts. All they show is what we might call deviations from normal or natural, right? So we have an idea about what a scan should look like, and whether that's abnormal or not abnormal, etc. And then what we're going to say is any deviation from abnormality is a problem. But what we were starting to learn about scans, about posture, about human beings in general, is our parameters of what is normal has been way too narrow for way too long. So as we learn more about the body, our parameters of normal become wider and wider and wider. So if you are 40, I'm 40, I'm an old bastard if you want to call me that, you are likely to have a back that is not the same as a 20-year-old. Part of what happens to us is our bodies change, our faces change, our muscle mass changes. We change as human beings from the day we are born to the day that we die, all right? And scans show those changes, but those changes are not directly relatable to pain. That's what we know from evidence-based medicine. So evidence-based medicine sometimes teaches us, not always the answer, but it often teaches us how to understand the problem better. And when it comes to scans, we need to understand the problem better, and that any deviation or abnormality or slight degeneration or change within our structure does not set us up for pain. There is no solid relationship there.
It's not so much the scan itself that's the problem, it's more the interpretation of the scan with regards to the person that's got them and their goals, ambitions, desires.
Or not just the person in relation to everyone else in the world. Because it's not, so we take 10 scans, one person has got pain, but 10 people have similar scans. So what's the thing that makes it can't just be the thing that we see on the scan that causes the pain, because there are 10 other people who don't have your exact pain. And even then, even if it was 10 people who had the same pain and the same imaging finding, would that pain be the same? Would the impact on life be the same? So there are so many variables we have here, from what we see as an abnormality to the pain that's experienced to the effect on that human being. And that creates a very individual and unique picture.
Yeah. Wow. Ben, I feel like I'm really getting some jazz concert time.
Yeah. By the way, I'm not very musical.
Yeah. But Ben, in all seriousness, I think this conversation really just highlights that, there's a human behind the experience, and, let's focus on that. And so this has been really fantastic. Ben, if you could boil everything that you have learnt and experienced in your professional career into just one solitary piece of advice to the listener of this show who's out there looking to be their physical best, perform at their physical best, what would Ben Cormack's one piece of advice be?
Wow. I mean, that's, again, a large question. I think, really, I think we have to understand that we're all individual human beings, and it's not best to judge ourselves against lots of other people, whether that's our pain experience, whether it's our performance experience. We are individuals, and, there's lots of things that we still don't know. And most of the answers that we can get to our questions are actually around the individual, not around people in general. So I think that's what we need to really focus on. It would be around being an individual and understanding that we are individuals.
And you mentioned don't judge yourself against others. I mean, that's the takeaway. I once heard a gentleman say the best way to kill something is to compare it to something else.
Well, you imagine people who are in pain compare themselves to people who aren't in pain. Athletes compare themselves to other athletes and what other athletes are doing. Therapists compare their knowledge to other people's knowledge. And people on social media compare their beauty to other people's beauty. And it's this we need to appreciate we are individuals. We have strengths, we have weaknesses, we have problems, we have solutions. But most of these things come from within us. They don't come from something that's globally right for everybody. And as I say, that might be training methods. It might be, even if we look at research actually, when you understand statistics, and I'm no statistical expert, but you understand statistics and you actually realise the numbers that get spat out, the mean numbers, are actually part of a much wider set of numbers. They're just an average. There is no such thing as an average person, an average response, an average treatment. We can't standardise treatment. Well, we can standardise treatment, but we get individual responses. So we need to understand we are individual, and comparison to how other people were fixed and comparison to how other people created success can give us information. It's not a blueprint. And I think that goes from people in pain to people working as physios or therapists in general to athletes to everybody. Most of our success comes from our own personal, and our problems can often come from within us, and we need to appreciate that and understand that.
Don't judge ourselves against others. So wise, Ben. Ben, every featured guest of the Physical Performance Show issues listeners with a physical challenge for the week. So what is Ben Cormack's physical challenge for the week going to be?
Go and do something you enjoy.
Go and do something you enjoy. Could it be any more pragmatic?
Again, people get locked in this idea of what they should do. What's the best thing to do, right? And that can actually limit people. I want to do this, but I should be doing this. Or this is the best way to get rid of my problem. Again, you're an individual. The best way to get out there and do something is to do what you enjoy, because you're more likely to do it again. So again, I think that's pragmatic.
Pragmatic and powerful.
I hope so. No one ever listens to me, by the way, Brad. Certainly not my wife. She hasn't listened to me in years, but that's for the Marriage Guidance podcast.
Ben Cormack, you're a real character, but it's such a great contribution to the world that I find myself in professionally. So I personally want to say thank you for all you do. And on behalf of the listener of the show, also thank you for your contribution on this episode.
Well, look, mate, I really appreciate you saying that. And look, straight back at you for having a platform for people to get out there and get access to people, lots of smart people, and then me, and other people who are inspirational. And I think we just need good, positive information out there. And I think you're doing your part for that.
Well, thanks, Ben. And if the listener wants to follow your journey, you have some fantastic professional courses, as you mentioned. Where can the practitioner find out more information on that?
Yeah, so my website is www.cor- the thing in the middle, kinetic.com. So Cor-Kinetic. It's just Cormack and movement, Cor-Kinetic. It sounds fancier than it is. I'm around on social media under Ben Cormack or Cor-Kinetic, Twitter, Instagram, and all those things. So if you can handle the crap for the couple of gems or the pearls that I put out, then then you come and interact.
Yeah, no, and you're an absolute must follow, Ben. I followed your work for some time, and I have to confess that I'm often reading them and rereading them just to digest the pearls that are in there. So listeners, jump over and follow Ben on Instagram, in particular, Cor-Kinetic, all one word. Ben Cormack, thank you once again for your contribution.
Yeah, cheers, mate. Thank you for having me on. It's been a pleasure.
So there you have it, another episode of the Physical Performance Show, and I trust you enjoyed today's episode featuring Ben Cormack. If you did, then please reach out and let Ben know. You'll find Ben over on social media, on Instagram at Cor-Kinetic, Corkinetic, and easily over on Twitter or via Ben's website, corkinetic.com. That's Cor-Kinetic, Kinetic.com. As prior mentioned, also keep an eye out for Ben and prior featured expert Adam Meakins' The Better Clinician project by clinicians for clinicians, launching shortly. And if you have questions from today's expert, Ben Cormack, then I know Ben will happily receive those and reply. So do reach out to Ben if you have a burning question that we didn't address in today's recording. Now, starting a new section of the show, each week I'll recap on my top 3 learnings. So here are my top 3 learnings from today's expert edition with Ben Cormack. 1. Dealing with people in pain is not a well-ordered orchestra, but rather it's like jazz music, a whole bunch of craziness and improvisation. The takeaway here as a clinician is that dealing with pain can be tricky. As an individual listening to the show, a performer, someone pursuing your own physical best, just note that the hours of sleep you have or haven't been able to manage, the stress that may or may not be there for you behind the scenes, your beliefs about your pain, the expectations you have about getting back to your best, these things all prejudice our perception of pain. Takeaway number 2. The dimensions of pain extend beyond the sensory dimensions of what we feel. As Ben touched on, there's the affective or the emotional dimension. That's how it makes us feel. Do we feel demotivated, threatened by pain? It's important to note, recognize, and be coached through this dimension by a therapist that truly understands that pain is more than skin deep. And takeaway 3, as Ben said, there is a special sauce in just having a therapist or caregiver be with you and understand you. It's so important that we feel connected to the people that we trust with our health. So the call to action there is, if you do not feel like you're getting care from someone that truly connects with you or understands you, then perhaps searching for someone that will give you that is really important. And certainly from a greater perspective in the healthcare system, let's not take the word care out of healthcare. Thank you to those leaving ratings and reviews over on iTunes. They are fantastic, very motivating, and they really are rocket fuel in bringing the show out each and every week, as are the podsies. They are wonderful. Please keep them coming. That's simply a screenshot of the episode you're enjoying and tagging in the show on social at Physical Performance Show, my handle as well, at Brad_beer. There has been a bounty of podsies coming through in recent times, so thank you for those. They're a whole lot of fun, and it's great to know what you're learning. That is the aim of the show, to inspire and educate you towards your physical best. So thank you. It's time to draw the winner of the $50 Amazon gift card for the 2019 Physical Performance Show Annual Feedback Survey. But firstly, a sincere thank you to those who completed the survey. I was astounded at the number of responses and have read each and every one of them and have taken all feedback on board. Some of the highlights and themes from the feedback include an overall listening satisfaction score of 90%. 85% of listeners that completed the survey said they would refer the show or recommend the show to someone in their world who is also looking to pursue and perform at their own physical best. 45% of responders indicated that they would like to hear an expert edition every 2 to 5 episodes. And what is the most popular episode type? Is it a featured performer, expert edition, interest edition, or coach's corner? Well, to date, the most loved format of the show is an expert edition. On the feedback side, there was so much received, and graciously so, but one of the common themes that emerged across multiple responses was the ability to ask the guests of the show a question once the show has gone live. Some responders said that they were appreciative of the fact that the guests will often intuitively ask the questions that they had in their heads. However, there are occasions when the questions that I ask as the show host don't cover the full spectrum or gamut of the questions that someone listening to an episode may have. So what we'll be doing for 2020 is throwing open a Facebook page where if you do have a question, you can post it up there, and following an episode going live, we will do our best to have a question answered from the featured guest of the week for you, and we will post the response live on the Facebook page. So if you jump over to Facebook and search the Physical Performance Show, there you will find the page. Now, there has to be a winner of the annual survey, and scientifically, it was chosen. How scientifically? Well, my beautiful 6-year-old daughter, Bella, selected a number between 1 and the number of responders that we had, and the magic number was number 8. So the winner of the $50 Amazon voucher for the annual feedback survey was none other than, a drum roll, Brad Rogers. Brad, thank you for taking the time, along with all others who left responses and completed the survey. We will get the gift card to you. Look out for your inbox for an email from me. Now, we'll also be publishing, without names, without responders, all feedback for the show over on the Physical Performance Show Facebook page. So jump over there and you can see some of the great feedback that came through. Now, it's not just annually that we want to hear how we can make this show better. Feel free at any point to reach out to me directly, b.beer@pogophysio.com.au, if you have a thought or a suggestion on how we can make this show better serve your listening needs. You can also jump over to the show notes, pogophysio.com.au/podcast, and there you'll find links for all of Ben Cormack's handles and also his website. Now, coming up on next week's episode of the Physical Performance Show, we'll explore the top Expert Edition sharings from 2019. Expert Editions really did light up throughout the year. It was a privilege to host some incredible guests, New York best-selling Times authors, world-regarded scientists and thought leaders in their space, and literally world-acclaimed experts on certain topics. So be sure to be tuning in next week for snippets of some of the deepest learnings as taught by experts in 2019. Until then, keep pursuing your physical best performance. I'm Brad Beer, and this has been the Physical Performance Show.